Ladies and gentlemen, this is Dr. Kazmi, and I'm going to discuss pain medicine conversion today. And this is for nurses and the doctors taking care of the dying patients or patients on hospice and palliative care. And we do have an equivalent chart, and the left-hand column has the equivalent dose of the morphine, which is 30 milligram, to the number I put there. So pay attention to that. And to start the pain management, you need to know the pain scale. Mild pain is less than 4, and severe pain is more than 8, and the moderate pain is between 4 and 8. It is really oversimplified. Between 4 and 8 is a moderate pain. And as I mentioned, the left-hand column here is codeine, 150 milligram equal to 30 milligram of morphine, and hydrocodone, Vicodin, 30 milligram equal to 30 milligram of morphine. Here the pain is less than 4, and you can start with the NSAID and adjuvant analgesics, and then add the codeine or hydrocodone. But in hospice and palliative care, we don't have much time, so we would like to start controlling the pain as soon as possible. For moderate pain, which is between 4 and 8, you can use the NSAID, adjuvant analgesics, and add the oxycodone, OxyContin, MSIR, immediate release morphine, or MS-Contin, which is long-acting morphine. Here, the oxycodone is 20 milligram equal to 30 milligram of morphine. So remember that. Oxycodone is a stronger, 1.5 times the morphine. For severe pain, either increase the dose of oxycodone or MSIR or MS-Contin or OxyContin you started, or choose hydromorphone, which is dilaudid. Here, 7.5 milligram of hydromorphone equal to 30 milligram of morphine. And methadone is another medicine you can use, which is cheaper, and for less than 600 milligram of morphine per day, the equivalent dose is about 3 milligram of methadone equals to 30 milligram of morphine. If the person is taking more than 600 milligram of morphine, then 2 milligram of methadone is equal to 30 milligram of morphine. If person is taking more than 1000 milligram, 1.5 milligram of methadone is equal to 30 milligram of morphine. And if you want to know the ratio, for less than 600 milligram of morphine, ratio is 10 to 1. 10 milligram of morphine equal to 1 milligram of methadone. Then a ratio is 15 to 1 if the person is taking 600 to 1000 milligram of morphine per day. Over 1000 milligram of morphine per day, ratio is 20 to 1. For Duragesic, you need to be careful also, and change the Duragesic patch every 72 hours or so, and 50% reduction for cross tolerance if the person is taking more than 300 or 400 milligram of morphine per day. And 7 microgram per hour is equivalent to 30 milligram of morphine. And the ratio is 4 to 1. Opioid conversion table is shown here, where left-hand corner has equivalent dose. Download that. Go to my site, hospiceteaching.com, or Hospice Short Notes, which is coming soon, and you can download that. I do have a formula where X equal to N divided by O multiplied by 24-hour dose of the morphine, where X is the new medicine you're trying to start, N equal to new medicine equivalent dose from the chart, O is old medicine equivalent dose from the chart multiplied by 24-hour dose of the medicine. And you put the numbers and you'll get total dose of the day. We suggest never to give long-acting medication more than every 8 hours, never crush long-acting opioids, never use long-acting medications for PRN or breakthrough dosing, and never assume that the patient is pain-free in terminal stages. And parenteral formulation are more stronger than other like oral and those are more stronger than IV is more stronger than oral medicine, obviously. We do not want to use meperidine or Demerol for breakthrough products because it causes cumulative toxicity. After calculating the dose, there should be 25% reduction for incomplete tolerance, and more reduction is needed, up to 50 to 75% for methadone and fentanyl. Methadone, be careful. The long half-life can lead to drug accumulation, which is the most feared thing in pain management, which causes sedation, confusion, disorientation, and gradually causes the respiratory depression, mainly in elderly population. QT interval prolongation is dangerous. So medications such as erythromycin, etc., should be avoided with methadone. Medication which decreases the methadone levels are rifampin, phenytoin, corticosteroid, carbamazepine, phenobarbital, St. John's wort, and number of antiretroviral medications. Meds that increases the methadone levels are tricyclic antidepressant, antifungal, conazole type, fluoroquinolone, amiodarone, SSRIs, diazepam, and grapefruit juice. We prefer to give methadone in 3 equally divided dosage. Advised to hold if too sedated. Use short-acting opioids or PRN, which is about 10 to 20%. For fentanyl, change it every 72 hours. And when you convert the morphine to fentanyl, go to the lower rounded number and use that one with the 25 to 50% reduction for cross tolerance. Increase or decrease any opioid dose by 25%, preferably every 48 hours or more. Give them some time to stabilize the dose, and then you can go up. Long-acting medications, once again, I tell you to give it to them every 8 hours or so. Long-acting medication should be seen as regular meals. You eat 3 regular meals. And the PRN medication should be seen as cookie or you're taking something in between the meals. And PRN medications are for breakthrough medicine, pain. Such as you're hungry, you're eating a cookie or so. And it should be 10 to 25% of the total dose. Oral, you can give it to them every 1 to 2 hours, and sub-Q and IV should be every 30 to 60 minutes. Adjuvant analgesics are co-analgesics. They alleviate the pain either alone or in combination. The medicines which are co-analgesics are Elavil, Trazodone, Paxil, Prozac, Cymbalta, Tegretol, Neurontin, Lyrica, calcitonin, capsaicin, baclofen, clonidine, dextromethorphan, neuroleptics, bisphosphonates, miacalcin, scopolamine, non-steroidal anti-inflammatory, and other local applications such as lidocaine, Voltaren gel, etc., and COX-2 inhibitor, that is Celebrex. Non-pharmacological measures are important as well. Do not forget them. Use all of them in combination to reduce the pain. Don't use agonist and antagonist with morphine, such as Stadol, Nubane, and Talvin. We recommend not to use a Demerol or meperidine because of the breakthrough or breakdown products are dangerous. Addiction is not an issue in terminal patients. So I do not want to erase that, and I want to discard that. And I want to tell them that if the pain is under control, patient will feel better. And addiction is a chronic neuropsychological and behavioral disorder. It's a compulsive use of the drug with loss of control despite harm. which doesn't happen in hospice and palliative care patients. For further reading, I suggest nlink.lurie.northwestern.edu or endoflife.stanford.edu, or you can download the presentation which I just did from hospiceteaching.com, and you can send us an email at hospiceshortnotes@gmail.com, or go on one of my sites and send me the information. Your feedback is important. Thank you.